Good evening, everyone. I'm very pleased to welcome you tonight to our webinar on common infants conditions in general practice. My name is Kathy Tepper and I'm from Eastern Melbourne, PHN. I'd like to begin by acknowledging the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and to elders past and present. Eastern Melbourne PHN is committed to the healing of country, working towards equity and health outcomes, and the ongoing journey of reconciliation. I'd also like to recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them, and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution they make to the development and delivery of health and community services in our catchment. Just a little bit of housekeeping to start with. So all attendees are muted. Please ask your questions via the Q&A box only. We will share these at the end of each presentation. Questions will be asked anonymously to protect your privacy. The session is being recorded and you will receive a link to this recording and a copy of the slides after the webinar. So our agenda for this evening, we're going to have Associate Professor Fan talk about the crying baby. Then we're having Dr. talk about neonatal prolonged jaundice, and finishing up with Dr. Chapakwenda talking about the 6-week check in general practice. I'll then finish up with a health pathways presentation and a closing at 8:30. So to introduce our speakers, Associate Professor Fan is a Melbourne-trained consultant paediatrician and neonatologist. She had 10 years training in Melbourne's major teaching hospitals at Monash Medical Centre, Mercy Hospital for Women, Royal Women's Hospital, Royal Children's Hospital. Additionally, she completed a PhD in neonatal medicine at Monash University. She's an associate professor in paediatrics and awarded a fellowship of the Academy of Clinical Teachers at Melbourne University. She's been working at the Northern Hospital as a consultant paediatrician and neonatologist for more than 15 years, and she is head of the neonatal unit. Dr. Tejas Doctor is a neonatology and general paediatrician. He has worked over 23 years' experience in neonatology and paediatric care, gained whilst working across several different hospitals and health networks, both in Australia and India. Tejas thoroughly enjoys the relationship he gains from dealing with both children and their parents. His first objective is to make sure the parents are always well informed whilst addressing their child's health and welfare. He prides himself on giving different options for each child's individual needs, along with a very high standard of care. And finally, Dr. Kelvin Chapakwenda is a consultant neonatologist and general paediatrician at the Northern Hospital. He is a graduate of the University of Zambia with a Bachelor of Science in Human Biology and a Bachelor of Medicine and Bachelor of Surgery. Dr. Chapakwenda commenced specialist paediatric training in the United Kingdom and was elected to the membership of the Royal College of Paediatrics and Child Health in 2008, prior to transitioning to the Royal Australasian College of Physicians specialist training. He worked in various paediatric subspecialties across the United Kingdom, New Zealand and Australia. Dr. Chapakwenda became a Fellow of the Royal Australasian College of Physicians in 2013, following completion of specialist training in neonatal and perinatal medicine, and also obtained post-fellowship specialist training in general paediatrics in 2016. Thank you, everyone. I'd like to now hand over to Associate Professor Fan for the first presentation.
Thank you, Kathy, for your kind introduction. Thank you, Kathy and Richard, for your invitation. So good evening, everyone. Today, the topic is crying baby. I will do a case presentation. Through this case, we will discuss some common conditions in infancy. And this baby JR, and baby boy, 6 weeks old, he was referred by his GP with concerns of irritability and crying. So his mother, Amy, reported that over the past 3 weeks, he has become increasingly unsettled and cries for a long period of time each day and worsening around the evening. It's difficult to get back to sleep when he wakes up overnight, and his parents are getting very little sleep. So they feel really exhausted. So his demand breastfed and is thriving, but he vomits small amounts immediately after most phase. He also has a lot of wind and passes many loose stools per day. So this real problem started. This poor mom would get all the different conflicting advice. So JR's grandmother is quite certain that he has colic and insists that JR's parents need to establish a strict routine. And his GP thinks he has a reflux, so convinced him on Ranitidine a week ago, and which seems to have made a little difference to his crying pattern. Amy's sister, who is a nurse, has wondered whether a change to a long cow's milk protein-based formula or a period of dairy-free diet for Amy would be helpful. So his maternal child nurse thinks that he has lactose intolerance because he has a lot of loose stools. So any thoughts regarding his differential diagnosis? Number 1, infant colic, and number 2, reflux, and number 3, cow's milk protein allergy, number 4, lactose intolerance, number 5, mother and the baby relationship, number 6, a normal crying could be. So regarding his history, he was born at term by emergency Caesar for obstructive labor and fetal distress. So he had a very good APGAR score, 8 and 9. His birth weight was 3.6. There was no neonatal problem. When JR came home from hospital, he would settle to sleep easily after each feed and sleep for several hours overnight. And he really cried and often slept through loud background noises. So JR is the first child in the family. Husband, or JR's dad, is a tradesman. He's very supportive and understanding. Both parents suffer from mild asthma and hay fever. They have a very caring GP and family support. There's no financial difficulties. On examination, he was well-looking, active, and alert, but he was irritable. So his growth, including weight, length, and head circumference, are all over 50th percentile. So basically, he had a normal physical examination apart from mild facial eczema. There was no evidence of infection, no abdominal distension or perianal excoriation. So just pay attention to this. It's a very important, actually, negatives. Which of following is not a normal baby crying? So crying is an attachment behavior ensuring survival and the development of social bonds. So this is correct. Yeah, this is very important because babies can't talk, can't express themselves. If a baby doesn't cry, something wrong. Up to 25% infants in the community cry excessively and are irritable. So it's quite common, 1 in 4 babies like to cry. Normal crying times have been lodge it as 105 minutes a day, so very precise for infants aged 2 weeks, and 165 minutes a day, so it's more than 2.5 hours, but less than 3 hours, at 6 weeks. Infants crying is most common in the evening, so I will explain why this is the case later. For most crying babies, crying and irritability decreases substantially by the age of 2 months. So number 5 is not normal crying. Yeah, so that's the correct answer for these questions. Normally, for most of crying babies, crying and irritability decreases substantially by the age of 3 or 4 months, not 2 months. When is a baby crying too much? When crying is persistent beyond the 3 months of age, like 3 or 4 months of age, that's not normal. Excessive crying is defined medically as crying that lasts at least 3 hours a day for 3 days a week for at least 3 weeks. Is there any pattern to the crying, or babies crying for many reasons, including like hunger, thirst, being hot or cold, wanting attention, or babies tired, or some discomfort, or some pain, or just the crying? So what are the common causes of crying? So usually crying is a part of a normal spectrum when babies have not learned to self-soothe and regulate their own crying. So if you suspect this baby is tired, when the infant's total sleep duration per 24 hours falls more than an hour shorter of an average for their age. So total sleeping time required over a 24 hours period in the newborn period is 16 to 17 hours. 1 to 6 months is 15 to 16 hours. 6 months to 12 months is around 14 hours. 1 to 2 years, 13 to 14 hours. So if you suspect the baby is hungry, if mom reported that a baby needs feeds like less than 3 hours, 1 or 2 hours, want to get on mom's breast to suck, and the baby's weight gaining is quite poor, this indicate, yeah, baby's hungry, mom hasn't got enough milk supply. Less than 5% of babies with a problem crying have an identifiable organic causes. In other words, more than 95% of babies, when they cry excessively, they actually don't have organic causes. Other causes of excessive crying, like infant colic, gastroesophageal reflux, food allergy, especially cow's milk protein allergy, lactose intolerance, or maternal and the family psychosocial state. So I'm going to talk in more detail these 5 issues. So infant colic is not a disease. So it's a behavior syndrome characterized by excessive paroxysmal crying over 3 hours, occurring over 3 days in any week for 3 weeks. Most to occur in the evening without any identifiable cause. And difficult to consult. The screening, and especially first-time mothers that really get very anxious. And that stiffen up the body, join up the legs, and red on the face, and the pulses flatters. Then they feel better. But they're feeding well and they're thriving. They're very healthy infants, age from 2 weeks to 4 months. So infant colic is a diagnosis of exclusion. Normally, this resolves spontaneously and it doesn't require any treatment. So, but it's very important to prevent maternal exhaustion and encourage short respite. Because we do have some tragedies occurred when mom exhausted and so tired, and the baby screaming, and sometimes moms don't know what they're doing. Even they just shake baby a few times, baby's brain will be gone. So it's very important, make sure mom has some rest. So regular follow-up and a sympathetic doctor are the cornerstone of management. And when I did a 1 day per week practice, private practice for over like 15 years in the past, I normally give mothers my mobile number that can contact me anytime. So I'll just worry about those moms, especially baby screaming. Yeah. So anticholinergic drug has been proven in clinical trials to be effective in colic treatment, but we should not recommend this drug because this drug has serious side effects. So, and when baby has wind, there are a lot of wind, and the baby screaming, a lot of people think that the babies are in pain. Actually, a lot of studies show that the baby is actually not in pain. So why the screaming like really like something hurt them? They're screaming because they don't know it's wind. And during the fetal life, like over 9 months, that's in the mom's womb, they don't need to swallow or milk or digest food, and there's no wind in the gut. They rely on mom for all the nutritions. So now suddenly they come out this so strange environment, and then the gut has wind, and this really scared them. They feel really insecure. Then the mom and the anxious make them more upset. So this is why anticholinergic drug is effective because it inhibits the wind. And when baby doesn't have much wind, and then they don't scream much. That's why it's effective. But normal gut should have a wind. If baby's gut don't have a wind, something wrong. So remember, don't give anticholinergic drug. Probiotic may have a role in the treatment infantile colic. Which of most effective method to manage colic? Probiotic, so still debatable. A maternal low allergens diet, like lower in dairy, soy, egg, peanut, wheat, shellfish, etc. Still not very convincing. And soothing music accompanied with parental attention, eye contact, talking, and touching, rocking, walking, and playing. This number 3 actually is the most effective method to manage colic. Oral hypotonic glucose and sterile water or infant cold, chemists are selling a lot of this colic medicine. Yeah, and the family spend a lot of money to buy. I don't think it's I don't think it's effective. It could have some placebo effect. And spinal manipulation in treating infantile colic, so shouldn't recommend it. So we do have cases and the babies had some spinal manipulation and become paralyzed. So an infant's crying, which can last from minutes to hours, and may actually be the results of missing and constant noise and stimulation of the womb. This may be the solution to a 3,000-year-old medical mystery of what causes a colic. So the new system that involves the 5S like swaddling, side stomach position in the parent's arm, shushing, swinging, and sucking can calm most crying infants. This can activate the baby's calming reflex. And during the first 3 to 4 months of life, by mimicking experience in the uterus. And most infant crying is not due to an emergency, but a baby's need for attention. And in many ways, newborns are not ready for the world at the birth and need that fourth trimester for gentle stroking, holding, and shushing. And I mentioned to you that I did give my mobile to some moms. And one day, this mom actually called me on Christmas Day, 11 p.m. She was so worried. She was panic. Background, her baby was screaming. She asked me whether she needs to take a baby to the emergency. So I asked her a few questions. I said, during the screaming episode, is your baby feeling well? Yes. Has your baby got temperature? No. Is your baby, when your baby crying, whether your baby has blue lips and, blue face? No. So I said, okay, take your baby to your bathroom. Switch on your hair dryer. So instantly, just immediately, baby's crying stopped. So that hair dryer, just like a mom's in womb, just like mom's blood flow, the shushing, just like that noise. So baby, oh, this noise, he heard for over 9 months. So he feels secure. It's a familiar noise to him. So swaddling very important for first 3-4 months, because when baby was in mom's womb, and it's very cozy and tight wrapped, yeah, and shushing and swinging, pregnant mom, quite active, going out and shopping and exercising, and baby love this swing. And some family, when baby screaming, and they try everything, then they take a baby for a ride around the blocks, and the baby crying stopped. So sucking, majority of infants suck some a finger from very young age. Most of infants start inside the womb. Sucking is a natural reflex for an infant, which provides a sense of security and contentment, and it's very relaxing. So this is colic. If you have a question, we can discuss in the end. So second problem, I'll try to answer the question why the colic is much worse in the evening, because I mentioned it before, mom's womb, the environment is very noisy, yeah? And because the mom's heartbeat constantly, and the constant blood flow, mom's bowel sound, just like a vacuum machine noises. So in the evening, and everything's quiet, yeah? There's no car noises around, and the siblings, in bed. So this is why evening is much worse. So, and I don't know whether you've been to our neonatal unit, and neonatal unit, just like a railway station, we talk loudly, walking in, very noisy environment, but most of babies sleep soundly, yeah. So they love noises. Okay, infants GOR. So GOR has 2 types. One is physiological, other one is pathological. So physiological, just functional. Yeah, baby can have a frequent vomiting, regurgitations, but they have a normal growth. They're feeding well, and they're happy. So just like a happy chaka said to the parents. And the pathological one, baby would have a irritability, like a very because of the acid regurgitation, and the baby linked that the pain with the milk. So they started to really not feeding very well. And during the feeding, they can have choking, coughing, apnea, and a very poor weight gaining. So this is pathological. We call it GORD. So it's a gastroesophageal reflux disease. So the major mechanism involves the increase in transit, lower esophageal sphincter relaxation. So factors that may promote GOR during the TROSR include increased intragastric liquid volume, maybe overfeed in the supine position, and the slumped seated positioning. So this can make a reflux worse. And signs and symptoms include like typical and atypical crying and irritability. Baby can have apnea and bradycardia and poor appetite, weight loss, or poor growth. Baby can have frequent regurgitations, vomiting, even back arching, can develop torticollis. Interestingly, some babies can have respiratory symptoms like wheezing and recurrent pneumonitis, chronic cough, sore throat. So why baby can develop respiratory symptoms when they have a reflux? Because the infant's proximal airway and the esophagus are shared with the same receptors which are activated by acid. So activation of these receptors can increase airway resistance and leading to development of a reactive airway disease. Microaspiration of gastric contents leading to inflammation and bronchial spasm. And also evidence supports the involvement of esophageal acid-induced reflux and bronchial spasm in the absence of frank aspiration. So when you treat this kind of symptoms, you use like respiratory symptoms like wheezing. The fentanyl is not very effective, but you use omeprazole will be effective. GOR can be diagnosed by the following. Number one, diagnosis can be made from the history and the physical examination. Conservative measures can be studied empirically. So this is the right answer. So it's a clinical diagnosis. Over, I think, 15 years ago, that time we did a lot of investigation, like berry swallowing, or gastric CT scan, or pH probe monitoring. These are three investigations that are not diagnostic, hopeless, yeah, just waste money and waste time. And the gastroscopy can make a diagnosis, but it's very invasive, only reserved for severe pathological reflux and failure to thrive. How to manage GOR? It's functional, functional baby is happy, baby, not screaming, they're normally happy, they're forming, but they're happy, and they're growing really well, so you don't have to treat. But you can also advise parents to keep baby upright for at least 30 minutes after each feed. That will help. And the prone sleeping or sleeping on the side is not recommended in infants due to the risk of seizure. And this supine, just sleep on the back, this recommended in early 1990s. So before that time, we hardly seen any infants with reflux because prone sleeping position actually increased gastric empty. Supine, sleep on the back, delayed gastric empty. That's why they have more vomiting regurgitation. But this method or this recommendation reduce seeds dramatically. So we want to baby to sleep on their back, yeah. And also up to 40% of infants presenting with symptoms of reflux would have a non-IgE mediated cow's milk protein allergy. So it's quite common in the practice. So maybe you can consider those babies vomiting, irritable, then you ask mom, to be dairy-free diet, or to, if it's a formula-free, you can suggest Alipro. So if make a huge difference, so that actually has a non-IgE mediated cow's milk protein allergy, rather real reflux. And also, if babies, bottle-feeding babies, you can advise use a thickener, and this can reduce frequency of vomiting. But you need to let the parents know that this may cause constipation and a block at the end, which is not going to help reflux. Yeah. So unless you put the baby on colic or etc. And use of Melanta in GOR is not recommended because there is no infant form. It's an adult form of Melanta, which has a significant level of aniline. So aniline absorption can cause osteopenia and neurotoxicity. So how to manage pathological reflux? So acid suppressant therapy may be indicated in a specific patient with gastroesophageal reflux disease. It should be instituted as a 4 weeks trial and cease at 4 weeks if no benefit. Yeah. Omeprazole is a recommended agent. Previously, assumed the safety of this medication is being challenged recently with evidence of potential side effects, including gastroesophageal or respiratory infections and the bacterial overgrowth, because acid is actually very important in the gut. And adverse effect for bone health, and also can cause a food allergy and drug interactions. Fund application should be considered for infants with complications like severe phenylketonuria, severe reflux, even baby has an esophageal stricture, etc. Okay, it's reflux. Next, I'm going to talk about cow's milk protein allergy. So infants with symptoms of colitis, relatively quite common, and the baby present with loose stools, rectal bleeding, abdominal distension, vomiting. Baby also can have atopic dermatitis, rhinorrhea, runny nose, or family history of allergies. What is the best test to diagnose cow's milk protein allergy? Number 1, skin prick test. Number 2, RAS test. Number 3, elimination and rechallenge. So diagnostic test is number 3. So elimination and rechallenge. So skin prick test and RAS test, this test only detect IgE-mediated reaction. Yeah, they're not 100%. They're screening test. Yeah. So, so if baby's cow's milk protein allergy is due to non-IgE mediated reaction, so test come back negative. But babies do have a reaction, yeah, to cow's milk. So number 1, number 2, they're not diagnostic. So between 2 and 7.5 for infants have cow's milk protein allergy. This reaction I mentioned may or may not be mediated by IgE. So cow's milk protein allergy resolves in most of children, up to 2 or 3 years of age. Those with a positive immunological testing results for IgE against the cow's milk protein generally resolve symptoms later compared to children who are IgE negative. In addition, infants with IgE positive cow's milk protein allergy are at a higher risk of developing other atopic disease like asthma, rhinitis. Okay, so how to treat cow's milk protein allergy? Which of the following is correct? So for breastfed baby, mother should continue with her normal diet. So, if mama on dairy diet, and that dairy can excrete to the mom's milk. So if a baby has a problem, so mom should be on dairy-free diet. For formula-fed baby, can try goat's milk. Unmodified animal milk is not recommended because they don't provide enough nutrition for infants' growth. For example, like if a baby just on goat's milk, not goat's milk formula, on goat's milk, and the baby can develop terrible folic acid deficiency, anemia. For formula-fed baby, can try soy protein formula. This is not good option either. So there is a 50% cross reaction. So also under 6 months, soy protein formula is not as good as animal formula. Yeah. So for formula-fed baby, can try amino acid formula first. Number 5, for formula-fed baby, can try extensively hydrolyzed protein formula first. These two all can be correct, but you compare these two options, amino acid formula like Neonatal tastes horrible, extremely expensive compared to Pepsi Junior. So Pepsi Junior tastes a little bit better and much cheaper, but will do the job. So the best answer is number 5. Skin, this already explained. This is explanation. Okay, so this is a cow's milk protein allergy. So lactose intolerance. Next, in our community, I think we overdiagnosed the lactose intolerance. So normally if baby has a milk intolerance, not due to lactose intolerance, actually more likely is due to cow's milk protein intolerance or allergy. Lactose activity in the fetal intestine progressively increases through the 3rd trimester and approaches maximum expression at term. So symptoms of lactose intolerance really develop in children younger than 6. Secondary lactose deficiency due to intestinal mucosa injury can appear at any stage, any age. For example, if infants or children that have gastro, that can develop secondary lactose intolerance. But infants are more susceptible. And lactose is, we shouldn't think that lactose or just sugar, doesn't have much, nutrition. So lactose actually is believed to enhance the absorption of several minerals, including calcium, magnesium, and zinc. So if a child or babies on lactose-free formula for a long period of time, so this child has a high risk to develop calcium, magnesium, and zinc deficiency. Will affect their bones as well. And also, in addition, lactase enzyme expression can be induced by lactose ingestion. So if we put a baby on lactose-free formula for such a long time, in the end, this child will develop permanent lactose intolerance because the gut lactase is an enzyme which digests the lactose. This enzyme couldn't be produced properly because this production is encouraged by a lactose stimulation ingestion. Yeah. Also, premature infants have a partial lactase deficiency because of intestinal immaturity. And we want to, we worry that, they will develop some milk intolerance. But if we introduce milk, mom milk, formula, whatever the milk, introphase earlier, the better. So that actually can decrease the feeding intolerance. And you introduce milk early to those 24-week, 25-week, 20, very extremely premature babies actually can help to induce the lactase activity. Okay, next question. Checking reducing substance is a diagnostic test for lactose intolerance. True or false? So a lot of people may say, oh, this is true, but actually it's false. Why is false? Because we couldn't collect a reliable sample. And most of babies use disposable nappies. To get an adequate liquidity stool is very challenging. So this test is useless. So how to diagnose lactose intolerance though? It's a clinical diagnosis. So you just remember two clinical features to diagnose babies who have a lactose intolerance. Number one, explosive diarrhea. So undigested lactose come out just like the rush out, like a shooting diarrhea. And it's very loud, explosive diarrhea. So parents wouldn't miss it. Yeah. So this is the number one features, clinical features. Number two, undigested lactose is very burning. It's very acidic. Also come out, rush out quickly and will burn buttocks. So if a baby has a broken skin around the anal area and plus explosive diarrhea, so this baby has lactose intolerance. You don't have to waste the time to do reducing substance. How to treat lactose intolerance? Number one, advise mother to be lactose-free diet. This is a wrong advice. Regardless, mom is on lactose or lactose-free diet or not, naturally, lactose will be excreted to mom's milk. Second, advise mom to stop breastfeeding and put a baby on lactose-free formula. This is the wrong thing to do because the breast milk is the best milk for baby's nutrition. You don't want to mess up breastfeeding, yeah? Number three, continue with the breastfeeding and commence the baby on lactase. This is the right answer. This is what we need to do, yeah, in the GP practice. So you normally prescribe lactase and that can buy from chemists. It's not that expensive. So continue with the breastfeeding. Before each phase, give drops of lactase. So then we'll digest most of lactose. So then give a baby a chance to heal the sore bottom. Once the bottom healed, then you decrease the lactase gradually. May take 2 or 3 weeks. And if you don't use the lactase, doesn't matter what the berry cream you use, that sore bottom is not going to be healed. So you have to use this way. Advise mother to express her milk, then treat all the EBM with lactase. This is very difficult to do, not practical. Also, I mentioned before, lactase production require lactose stimulation. So therefore, you don't want to remove all the lactose. Other symptoms of excessive cry and like a difficult in feeding, maybe due to blocked nose, we need to check. Common sense common. And vomiting may indicate a gastrointestinal problem. Excessive straining may be due to constipation. So this is why baby screaming, crying. And eczema suggests the discomfort from itching. So how would you manage JR? And then we'll go back to the case I presented at the beginning. So I feel that JR is a very healthy and a thriving baby, so I reassure parents. And there was no evidence of reflux, advice to cease ranitidine, advice regarding the resettling techniques, and discuss strategies, how to deal with JR's crying episode. But the mother was not happy with me at all with the initial consultation. And she believed that something serious wrong with JR. And she looked very sad and depressed. There was no interaction between JR and his mother when I observed them. Talked to her husband Nong. He was very teary and admitted that his wife was driving him crazy, and she was crying most of the time. So at each consultation, counseling regarding positive thinking, interacting and enjoying her beautiful baby. So I feel that she needs help, suggest the mother-baby unit for her and JR. Mother rejected and wanted to sort out JR problem first. Mother went off for breastfeeding as it was too difficult. Trial for Neonatal by another pediatrician for 2 weeks, as he had eczema and loose stools, but without any effect. JR's ranitidine changed to omeprazole by another doctor. So she actually did a doctor shopping. One day I got a call from ED at the RCH. JR was brought by his mother to ED for investigation. Fortunately, and this was refused by the doctor as JR was healthy. Many calls from his mother for urgent consultation, but JR was well. So eventually, his mother agreed to be admitted to mother and baby unit for her depression management. And I reviewed JR at 4 months of age. JR and his mother both happy. So when you see babies with excessive crying, and the 3 key questions you need to ask parents. Has your child had a temperature or poor feeding? Does your baby turn blue or have trouble breathing when crying? Are you so tired of hearing the crying that you are afraid you may hurt your baby? So there's 3 key things when you examine the baby. You need to exclude otitis media, strangulated hernia, torsion of testes or appendix of testes. What is the role for the doctor? So we need to explain baby's normal crying and sleeping patterns to assist the parents to help their baby dealing with discomfort and distress, to assess mother's emotional state and the mother and baby relationship. When to be concerned about baby, and if baby continues to have a feeding, sleeping, and distress problem beyond the 3 months of age, or baby avoid gaze, and baby withdraws emotionally and doesn't respond to parents when not crying and doesn't enjoy play. So this baby really needs a further investigation or evaluation. When to be concerned about mother. So if mom next empathy, makes hostile comments, even say, then not bonded to her baby, or also otherwise indicates a mother-baby relationship problem, and the mother is unable to follow advice. Mother feels persistently angry or continues to report anxiety or depression symptoms after baby's crying improves. These last slides illustrate the interaction of a mother and infant's distress. So from right-hand side, mother may have some social cultural beliefs about infant's behavior, and being a good mother. And if baby is crying, very unsettled and crying, and she feels that she's inadequate, she's not coping, and she may, like the case we discussed earlier, and Amy had a quite traumatic birth, and this also could be risk factors for her to develop postnatal depression. So and also mom could be very anxious as well. And from baby point of view, so suddenly from intrauterine environment come to the this strange world, and baby needs time to get used to baby's own body function, also environment. But then baby can sense mom's anxiety and distress, and this make baby more upset, feel more insecure. So just the mother and the babies, they have this kind of visual cycles. Okay, so thank you for your listening.
Thank you, Archie. That was a very interesting presentation. We haven't got any questions in the Q&A box at the moment, so perhaps we can move directly on unless someone wants to put a question in there. No, but we'll move straight on then. I'd like to introduce now Dr. Kelvin Chapakwenda to do the next presentation.
I'll just go.
I think it's Tejas, isn't it, Tejas? I think it's Tejas.
Sorry, Tejas.
Yeah.
Tejas, you'll just need to come online to start your video.
Hi, can you see the slides?
Yes, we can.
Okay, thank you. Hi, guys. I'm just going to present one of the very important topic in neonatal care about prolonged neonatal jaundice. I think you guys have all been familiar with the jaundice and other thing, but what happens when the jaundice go beyond certain limit? How much to investigate and what to investigate? So look, I would start with one case, which is actually a real life case that I witnessed. And after that, we would look into the basic science thing, like about bilirubin metabolism, Then we'll review some of the causes and how to investigate a child who present to you with prolonged jaundice and what exactly the prolonged jaundice is anyway. Okay, so we'll start our presentation with that. You feel free to write your comment and question in your comment box, and then we can answer later. Thank you very much. Okay, so this is actually more or less what I witnessed or we saw as a case. So male infant was born at 29 weeks to a primary gravida mother. This was kind of a tertiary care center, but not a quaternary care center, like not having very good surgical input. Obviously, with gestation that the patient had needed CPAP and TPN for some time, baby's course was complicated with jaundice, sepsis, PDA. Unfortunately, baby also developed necrotizing enterocolitis. So because of that, the feeding was stopped and baby needed TPN for very long time, like maybe 2-3 weeks before baby could be switched over to feed again. Because baby was very unstable, received some blood transfusion for anemia as well. After around maybe 3-4 week time, baby was looking more jaundice. And then SBR was done. So baby was always jaundice, but the intensity sort of went up. Baby was, and the SBR was done, which was 108 micromole per liter. But the direct component or direct bilirubin was 68 micromole per liter. And we will go through that, what exactly it means and why is it significant. So the team thought that, because baby received TPN or total parental nutrition for so long time, it may have been because of that reason. So temporarily TPN was stopped and baby was sort of monitored, but there was no improvement in the jaundice despite of that. Also liver function tests show some rise in gamma GT and some deranged ALT. Baby had little bit of hepatosplenomegaly on ultrasound, but gallbladder, when the ultrasound was done for the liver, was not visualized. Baby was investigated further, like the TORCH screening, thyroid test, blood culture, metabolic screen, all the screen were done. And then baby had nuclear scanning to make sure that, bile duct canalipidi are okay or not. All this investigation took place. By that time, baby was already maybe around 3 months old. By the time all the reports and improvement and everything was done, HIRA scan didn't show any uptake of radioisotope and also there was no excretion to that, which is concerning. So baby was actually transferred to a center who can actually look after bile in an operative table. So baby had an per-operative cholangiography and also liver biopsy, which indicated that baby probably has a diagnosis of biliary atresia. But by the time we reached to that diagnosis, it was already 3.5 months probably. So baby was offered a procedure called as Kasai procedure, which was done, but unfortunately it failed in next few months, and baby was put on need for liver transplant list. And ultimately baby had a liver transplant when grew up to 2 years of age, but needed lots of medication and management and serial visits with the gastroenterologist to be looked after by himself. So this is what exactly happened here. An important diagnosis was a biliary atresia, and the keyword was prolonged jaundice, which took a while to sort of investigate and thought that it could have been because of some other reason. It was a instructive learning case for when I was in a training. This was probably one of the important case that I had gone through in my life. Anyway, we will start with some definition just to give an important idea. What is jaundice? I know everyone knows about it, but what are the critical important thing in jaundice is? Many times when I see patients in clinic and when they look jaundice, some parents are quite worried to see yellow discoloration of skin for their babies. I always tell them that, I haven't seen a child who is not jaundice. Majority of baby will be jaundice, and it's a physiological thing. because the liver maturation or glucuronation does not start till 4-5 days. So all of them, the end metabolic product will look jaundice. When they look the jaundice is by definition any SPR or serum bilirubin more than 17 micromole per liter. You can clinically see jaundice when SPR goes beyond 90 micromole per liter. That's where it is visible to us. Severe neonatal jaundice, this is important for you in case if you are doing jaundice test on some of the baby, and if it is more than 420, it is kind of considered as severe jaundice. The reason why we categorize that as severe, because these are the kind of babies who are at very high risk of bilirubin induced neurological disorder or toxicity. And extreme neonatal jaundice is the jaundice when the level goes beyond 525. Something that I have not seen a lot in my career since I came here in Australia. The most important thing we need to learn is how the bilirubin is formed and how is it metabolized. The reason we need to learn this is, or the reason we need to look into this is, so we know that what are the important component that we need to find out in case if the jaundice is, we are investigating a child who has jaundice going beyond certain age. So as we know, it's a byproduct. So red blood cells, they are formed and they go through hemolysis. Now it's very important to understand here. So babies are born with relatively higher hematocrit. Their hematocrit is quite high because of intrauterine relative hypoxic environment. They have lots of RBC mass in it. Not only that, the important thing is the lifespan of RBC in newborn baby is considerably less than adult. So adult hemoglobin or adult RBC has lifespan up to 120 days, while in newborn it would be around 60 to 80 days or probably sometime 90 days. Preterm baby, it can be even shorter. What it means that there is lot of breakdown of red blood cells, which is kind of a normal occurrence because so many red cells are available and they break down so often, so frequently. There is lots of raw product that is produced, which is heme. That heme ideally is acted by heme oxygenase, which is one of the enzyme which converts that into biliverdin, and biliverdin will be converted in bilirubin. So bilirubin can be free bilirubin, which is what you called as unconjugated bilirubin, or bilirubin can be bound with albumin. Okay, and when the bilirubin is bound with albumin, it goes to for conjugation in liver. There is an enzyme which it is important for us to know this enzyme, which is called UGT1A1. This enzyme is important in some of the very less common jaundice that can occur because of the abnormality in this enzyme. This conjugated bilirubin through bile duct will go to intestine, and where it will be acted upon by bacteria, and it will be changed to stercobilin and urobilinogen. Urobilinogen will be sent to kidney and they will be excreting the urine, and stercobilin will be going through the feces with passes stool. Now you can see there are several steps and anything can go wrong. We don't see a lot of problem with the heme oxygenase or biliverdin reductase. Many times you have abnormality in UGT1A1 enzyme activity, and because of this, conjugation of bilirubin is hampered, and this conjugation doesn't occur in liver, and because of that you have rise in unconjugated bilirubin. Now there are three distinct syndrome. One is called Gilbert syndrome, which is very common occurrence, and two are Crigler nature, type 1 and type 2. Type 1 being very severe, and they need very hard time to treat, and type 2 is less severe, but they are all responsible because of the enzyme activity, which is very low or indetectable or present but less. Gilbert is the mildest form of syndrome. Generally, they don't need any treatment. Patient would appear jaundice and there will be unconjugated hyperbilirubinemia, but they don't cause any harm to the patient. So Okay, so the reason why kids are or newborn babies are more jaundice is because of the main important thing is short lifespan of the RBCs, massive amount of red blood cell present in their blood, and also this enzyme activity in newborn, though it is present but it is not yet active. It takes time to activate after they're born. Generally kicks in around 3-4 days and peaks around after 5 days. That's why the jaundice would pick up during that time. Okay, now if anything goes wrong with the bile duct, or if there is no bile, that means the conjugated bilirubin is formed. It should have gone to the intestine, but because of the bile duct problem, it can't go to the intestine. It will accumulate in liver, and ultimately it will spill into the blood as conjugated hyperbilirubinemia. And that's where we see a problem like choledochal cyst or biliary atresia. All those problems is because of this bile duct issue. Okay, so this is an important basic science slide which helps us in understanding the bilirubin pathology. We'll go further now. So it is very important to understand that jaundice, the peak time and resolution for jaundice varies with infant's age, infant's gestation. So premature baby, peak is bit later, resolution take longer time. It also varies with ethnicity, where East Asian people, they will have more later peak and more prolonged jaundice. And sometimes with the underlying condition, like if baby is unwell with sepsis or there is ongoing hemolysis, they will have more problem in delay in resolution as well. In term babies, generally 48 to 96 hours is the time when they peak, when the jaundice level normally peak. It can be late in East Asian, can go up to 70 to 120 hours. Majority of time, the serum bilirubin level of 300 micromole per liter is the 95th percentile, meaning it is very, very high level of normal. Okay, that is in majority of the situation. Again, this also depends on the gestation and day of life. Clinical jaundice resolves mostly in 7 days in formula fed term infant. However, it can be late in East Asian ethnicity, where it can go up to 10 days. 85% of infant jaundice resolved by 14 days of life, 85%. However, that's the reason persistence of jaundice beyond 2 weeks is technically we call as prolonged neonatal jaundice. Now, in some authority, they call it after 10 days as well, but majority of time, and this is what we take in our account, like any jaundice beyond 2 weeks in a term baby is prolonged neonatal jaundice. Most of the time, when you see child with prolonged neonatal jaundice, this is because of benign condition like breastfeeding jaundice. However, it is very, very important to investigate any child who has persistence of jaundice beyond 2 weeks of life, is just to rule out some of the clinically important causes like biliary atresia. Okay, and we would certainly go through some of them. So the most important thing whenever you see a child who has jaundice beyond 2 weeks is to differentiate whether the jaundice itself is a conjugated jaundice or unconjugated jaundice. And there is a reason for that, because the causes for conjugated and unconjugated jaundice are quite different. But the question arises in our mind that how do you define that this is conjugated jaundice and this is unconjugated jaundice? Can it be mixed? And if it is mixed, how do you know that this is conjugated or not? Okay, so the definition of conjugated jaundice is where direct bilirubin is more than 17 micromole per liter, then bilirubin when direct or conjugated bilirubin is more than 17 micromole per liter, and total bilirubin is less than 85 micromole per liter. And if direct or conjugated bilirubin is more than 20% of total bilirubin, whenever the total bilirubin is more than 85 micromole per liter. So you need to see the total bilirubin first. Okay, if the total bilirubin is less than 85 micromole per liter, and the other hand, the conjugated bilirubin is more than 17, that's significant. That's conjugated hyperbilirubinemia. If the total bilirubin is more than 85 micromole per liter, then what is the 20%, 25% of that bilirubin? Whether the conjugated bilirubin is more than that or not, then it defines the conjugated jaundice. Okay. The most important thing is conjugated bilirubinemia is never physiological. Even though it is less, it is not physiological. It is not benign. That babies who have conjugated hyperbilirubinemia must be referred urgently, or they need to be investigated further. Okay. While unconjugated hyperbilirubinemia, it can be because of either bilirubin or overproduction, or defect in bilirubin conjugation, or reduced uptake by the liver. Okay, any of these things can cause unconjugated hyperbilirubinemia. This can be benign, or it can need some treatment, depend upon the cause. Okay. Conjugated hyperbilirubinemia is generally either because of hepatocellular injury, means something goes wrong with the liver, like liver infection most of the time, or liver infiltration by metabolic process or any other process, or congenital defect in bile excretion. These are the surgical issues where bile is produced normally but cannot be excreted by liver. Okay. Many people, when it is conjugated hyperbilirubinemia, is also called as cholestasis, which is used interchangeably in literature, and they both are same. So this is very important approach for all of us to remember. So unconjugated hyperbilirubinemia, if the bilirubin is unconjugated one, predominantly unconjugated, then either it is bilirubin overproduction, meaning lots of bilirubin is produced. That happen because of hemolysis, like lots of RBCs are there, they are being killed very easily, and because of that lots of raw production and bilirubin overproduction because of that. Now it can be extravascular, like blood extravasation, or spleen that is bigger and that is killing, or hypersplenism, or intravascular hemolysis, which include G6PD deficiency, sickle cell disease, spherocytosis, elliptocytosis, and sometimes autoimmune hemolysis, all those things. Or there can be impaired hepatic bilirubin uptake. So bilirubin, when they are going to come to liver, before that uptake is impaired, and that happens because of suppose patient has heart failure, and in those congested liver failure, in those situations bilirubin cannot go into liver, and that's why they have unconjugated hyperbilirubinemia. And the last thing is there is impaired bilirubin conjugation. As we know, the UTT1A1 activity, if it goes down in inherited form, this can be Gilbert syndrome. And as I mentioned, Gilbert syndrome is one of the very, very benign syndrome. Many kids are there with Gilbert syndrome, but they don't need any treatment. Generally, they are very benign. Every now and then, whenever they are infected, they would have higher unconjugated bilirubinemia, and that's all. But none of them would need treatment. While they can have Krigler-Nager is it's a severe form of disease where who would need treatment, lifelong phototherapy, and other things. There can be acquired form of conjugation issue, which happens in thyroid problem, some drug induced, or some hepatitis reason. These are the reason where conjugation is deranged in those situations. Okay, this is in nutshell whenever there is unconjugated hyperbilirubinemia. So prolonged jaundice, that is jaundice beyond 2 weeks of life. First, we have to determine whether it's an unconjugated and jaundice or whether it's a conjugated hyperbilirubinemia. And these are the reason why unconjugated hyperbilirubinemia can present, and that's the reason for that. Now, when you have conjugated or cholestasis, the reason can be TPN, in particularly children who spend a lot of time in special care nursery or NICU where they receive TPN for so long. That probably is one of the most important cause of cholestasis in newborn. But the second most important cause, and which is very severe or serious, is biliary atresia. Choledochal cyst is another surgical problem. Sepsis, hypothyroidism, metabolic problem, alpha-1 antitrypsin, and some of the genetic syndrome like Ehlers-Danlos syndrome and other syndrome. They are all important cause for cholestasis. Okay, and they really need referral. Now I would tell two of the most important unconjugated and two of the most important causes, and we'll go into detail of those things. Okay, and ultimately we will turn what to do when we see a child or baby who is 14 days and above and still looking jaundice, how to approach them. Okay, so one of the important cause that we see is breastfeeding jaundice. This is unconjugated jaundice. Lots of studies have been done to find out what is the exact reason why breastfeeding child have jaundice, but unfortunately there is no good mechanism. There are suggestions that beta glucuronidase, which is present in breast milk, inhibits conjugation. There is also suggestion that there is genetic tendency that some babies do have more breastfeeding jaundice in comparison to other. But the good part of the story is that this is extremely benign situation. Infant who are on exclusive breastfeeding can have bilirubin more than 85 micromole per liter on many occasions. Generally, they start having jaundice from 4 to 5 days. They peak around 2 weeks. So, this is the time when they present to that looks more yellow than before. So peak around 2 weeks and resolve by 4 to 2 weeks, so 4 to 12 weeks. So if you just follow them, they would be fine. I remember in India, it's not a good practice to do in India to diagnose this condition because there is no way you can diagnose. It's a diagnosis of exclusion. So generally, in India, what I remember that, when we used to ask the mom to stop breastfeeding for 2 or 3 days and repeat the serum bilirubin after that. It would resolve the thing, that would diagnose. That's not recommended because this condition is a very benign condition. It would never push the bilirubin high enough to warrant any sort of treatment. Okay. So generally very mild and it does not need any intervention. You can reassure parents that, that it would slowly resolve in 2 to 3 months. And that's what happens in most of the situations. But on the other hand, when we are dealing with conjugated bilirubin, this is a diagnosis that we should not miss. And we have to diagnose in a timely fashion as well. Okay. It involves extrahepatic biliary tree. It is responsible for 20 to 30% of neonatal cholestasis. Out of all conjugated hyperbilirubinemia, at least 20 to 30% can be because of biliary atresia. Generally, babies are healthy at birth. There are some studies which says that even though the bilirubin mild conjugation was always present, even early in life, but the progress is at 4 to 6 weeks, and this is where parents present that my child is getting more and more yellow. Not only that, the other important part of history will be pale color stool and dark conjugated urine. These are the other factors that would present with the baby as well. This condition must be recognized within 60 days because the operative procedure named as Kasai procedure should be offered to them within this time frame. Otherwise, the operative outcome may not be as good as that. Even in base center, sometime even if with optimum management, many of the kids can actually go and need liver transplant, and that probably is the ultimate management for the babies. But if you recognize early, like suppose at 1 month we recognize, it's a good time frame, and then baby can be referred for a Kasai procedure, which is a better one. Because liver transplant may or may not be available for a long time, and it would be a difficult thing. And now the best important thing is, what shall I do when I see a neonate with jaundice? And sorry, I should say neonate with a jaundice beyond 2 weeks of life. So the most important thing is to ask in history whether baby is exclusively breastfed or formula fed. Is there any history of dark color urine or pale stool, which is very important? Is the child looking anemic, which is a cause of hemolysis? All the unconjugated hyperbilirubinemia because of hemolysis, or They also look anemia because they have acquired congenital cytomegalovirus, or sorry, they have acquired CMV after they were born, and they can look anemic because of that. Whether the child on examination has hepatosplenomegaly, that's another important thing to look into history and examination, because hepatosplenomegaly would point towards an etiology of hemolytic jaundice or cytomegalovirus infection. Then it is very important to consider initial blood test or preliminary blood test. That should be serum bilirubin, that include conjugated bilirubin and unconjugated fraction, a full blood count, which most likely we will see whether there is any evidence of hemolysis. Some people do include reticulocyte to find out whether the hemolysis is there or not. I generally include liver function test at that time to make sure that liver is otherwise normal. And because thyroid hypothyroidism can present with either conjugated or unconjugated jaundice, and not only that, it's one of the very easy to treat condition, and if we miss it can have big problem on baby's developing brain. So I generally, in my preliminary test, I generally include thyroid function test, mainly TSH rather than anything else. After reviewing the results of the first tier test, only I would go to second tier if it is necessary. Like suppose I find evidence of hemolysis in the patient, then I would look for G6PD, whether the patient is from Asian ancestry, or I look for other evidence of hemolysis on the patient. Or if there is conjugated hyperbilirubinemia, then I go on to the path. I would do the liver ultrasound, I would do torch panel and other investigation. But whenever I see conjugated hyperbilirubinemia, I generally like to discuss with other people. In your case, either you should refer to pediatrician or pediatric gastroenterologist, because it is very important to sort of investigate fast and find out if there is any problem. If patient has unconjugated bilirubinemia, which is very mild and has no anemia or any evidence of hemolysis, then it is very important to just reassure parents and follow up with them, that and then look at later clinically. See, you don't necessarily have to repeat the SBR. If clinically it's going down, it is fine. Probably that means the patient may have breast milk jaundice, which is resolving now. If conjugated, I think at your stage, I would appreciate urgent referral to pediatric services or to the pediatric gastroenterology service for further investigation, because baby is likely to require more tests than what you would anticipate. We may consider you may want to consider liver ultrasound in interim while patient is waiting to be seen by the specialist. I think this is all for the thing, and I'm open for any question or answer if you have any.
Thank you, Tejas. We haven't had any questions come through on the Q&A box. So thank you very much for your presentation. We might move on to the last presentation. Kelvin, it's over to you. Thank you.
Thanks, everyone. Thanks, Tejas, for that. I'm just going to load, and I was just waiting for him to stop sharing. And congratulations, everyone. You have made it to almost 20 minutes to go. So thank you for your audience. Let me just find my presentation. Here we go. Okay, so my talk today, which is very sort of targeted, is about the 6 weeks check or infant 6 weeks assessment, whatever you're going to call it. And in looking at this, I will be looking at a few objectives. So we'll try and review what the why and how. Why do we do it? How do we do it? and
highlight
some of the, Tejas, your mic, and can you mute yourself? Thank you. And I'll be mentioning a few of some of the referral pathways.
Sorry, Kelvin.
Kelvin, you've been muted.
I've been muted. Can you hear me now?
Yes, we can. Thank you.
I'm not sure how long I was muted.
Just the last screen, I think. Thank you.
Okay. All right. So the key thing is we're looking at why we do it. So what is the purpose of the 6 weeks check? Now, it's important to remember that the 6 week check is a core component of the child health surveillance. And child health surveillance begin well in utero with your morphology scan and subsequent obstetric surveillance that comes with it. And it is followed by the newborn examination, which would normally be done in the hospital for those babies who are born in hospital. Some of the general practitioners might do the newborn examination for babies who are born at home, and they present to you maybe on day 2 or day 3 for assessments. And then we have the 6 week check, which we'll be talking about today. But all these are child health surveillance, an important part to make sure that we don't miss conditions that we can screen for. They are screenable conditions, and we have to pick them up so we can manage them early. And that's the purpose of the child health surveillance. That includes the 6 week check. Why do we have a 6 weeks check when we've already had the newborn examination? It's because some of these conditions will present late, and therefore we want to pick them up when we have the opportunity to do so. The structure that we normally would go through or would recommend that we go through, what I forgot to say to you was that this surveillance has been established, especially in other countries where they've got even standards to look at, and they've got competencies that have been established in how do we perform it, and they can actually audit those assessments and competencies to make sure that we're doing the right thing. In the UK, it's called the Newborn Infant Physical Examination Program. And it's, like I said, it's part of the core feature of the child health surveillance. So the structure of this 6 weeks check starts with the history. And in the history, it's very important to go back to the prenatal to just have an understanding what were the issues, if there were any prenatal issues or maternal issues. Through to the neonatal period, you are seeing this child maybe for the first time at 6 weeks. And so we want to know what were the issues before this child was born, and be able to review the newborn examination if there were any issues arising from that period as well. There might be some babies who have been flagged to follow up certain things following the newborn examination, and we would normally record those in the baby's green book. So looking at that newborn examination and whether there were any recommendations for follow-up made. It is an opportunity to look at the family concerns, and families may come to you in addition to having a routine check. They have concerns that they would like to discuss, and so being open to allow them to do so is very important. It is also an opportunity to do a general evaluation and to be able to pick up some common conditions that might present beyond the newborn period, beyond the newborn examination period. It is also an opportunity to look at the growth and the development of this child. But most importantly, we want to screen for specific conditions. And I'll spend a few minutes just looking at those specific conditions because they're important. The goodness of the 6 weeks check is that we're assuming that most of the acute things, most of the things that we need to pick up, especially we're looking about dysmorphology, dysmorphic features, abnormal structures and so forth, that we probably have picked them up before these babies have left the hospital or at the newborn examination time. So whilst it's important to be thorough, there are a few things that we need to pay attention to. And those screenable conditions are the ones that I'm going to pay attention to, given we've got only 20 minutes to cover this. The most important things as well during this 6 weeks check is to be able to identify infants that are at risk. These could be infants with the background of maternal mental health problems, or they've got learning difficulties. The learning difficulties, families might have been identified before they left the hospital, and enhanced maternal child health might have been put in place and so forth. There will be those that may have been missed with poor housing issues and so forth and so forth. So identifying the infants at risk is important at this part of the assessment. It's also an opportunity or a forum for health education advice. Now, the health education advice might not necessarily come from the general practice itself or the practitioner itself, but might come from the practice nurse and might come from other allied health support services within the practice. So things like breastfeeding and directing parents to the National Breastfeeding Hotline. If they've got any concerns, they might be referred to lactation consultants and so forth. It is time to review that these babies are sleeping the right way and they have the correct information about prevention of cot death, and that there is safe transportation in cars, they're using the right car seats and so forth. It's the time as well when we collect some baseline anthropometric measurements that will help us ascertain that the child is growing appropriately. And this is the time as well to give routine immunization, so the 6 weeks immunization. So that's the structure of how this proceeds. But the most component also will be a physical examination. And during the physical examination, just like we teach in the newborn examination, it was going to be a top to bottom look, and understanding the normal so that we can identify the abnormal is very important in these babies. But like I said, the abnormal babies with abnormal appearances and with suspected genetic conditions or suspected metabolic conditions hopefully would have been picked up by then with a combination of the physical examination of the newborn, but also with a metabolic screen that is performed routinely with more and more conditions being added to them at 48 hours, 72 hours of life. So we're hoping that those conditions would have been picked up. They shouldn't be waiting for 6 weeks check. But there are specific conditions that we will want to look out for during this period of assessment. And one of them is cataract, since we are starting at the top, going to the bottom. And congenital cataract is one of the commonest form of preventable childhood blindness. Preventable, and therefore that's why it should be screened for, picked up early, and treated early. About 2 to 3 children in 10,000 births are born with cataracts in one or both eyes that will require treatment. So it's worth picking them up to avoid a blindness. And so to be able to identify cataracts, we'll be paying attention to that eye examination when we're doing it with our red reflex, eliciting that red reflex it's important to remember that if you see dark spots in the red reflex, like the picture that you have here, this is, it may not necessarily be red, but it's got white, and then there's some black spots in the middle. Imagine the rest of the parts looked a little bit red. In those areas where it looks white, the pupils looks white, they were a bit red or pale red, but you're seeing black spots. That's a concern for cataracts. And during this assessment, parents should be asked whether they have any concerns about the child's vision. It's 6 weeks time. The baby should be able to focus on the face. They can look at the carers' faces. They smile back with excitement and so forth. They can follow the face through the midline. So if there's any concern of perception, visual perception, then we should pay attention when we're doing this eye examination. One thing to mention as well is just to be aware of an eye that looks a little bit bigger than the other side, because that could be a sign of glaucoma. And this is something that can develop later beyond the 48 hours newborn examination that was done early. Therefore, we don't want to miss it. An important part to mention here whilst we're talking about the eyes is esotropia. Now, converging squints are very common. About a third of newborns are born with intermittent exotropia. But when you see esotropia, it's not normal. And what is esotropia? Esotropia is when one of the eyes, it's actually one eye, is deviated towards the nose. And it's persistently like that. That's not normal. So those children should be referred for an eye assessment, not to the pediatric clinic, but to the ophthalmologist, to the eye specialist, because we are not going to help them. We'll be making a referral on as well when we see these children. So it's important to know where to send them. So an important condition that we need to screen for at the 6 weeks check, going down to the chest, is congenital heart diseases. Now, a lot of babies or infants will have murmurs. They are very common audible sounds when you auscultate the precordium. But only about 7 to 8 in 1,000 newborns are born with a heart condition that needs treatment. And we know that most of the murmurs, most of the cardiac murmurs that we hear would have disappeared by 6 months or so. And 8 to 90% of murmurs found in the neonatal period disappeared in the first year, most of them within the first 3 months of life. But about a small percentage of those might still persist despite having a normal cardiac examination. So the most important thing is to look for signs of potential heart disease in addition to determining whether this is an innocent or this is not an innocent murmur. If the murmur has never been heard before and we're hearing it at 6 weeks, it sounds pathological. Pathological murmurs will be murmurs that are loud. They radiate beyond just the apex. You hear them in other places. There's an associated heave when you put your hand on the chest, or there are diastolic murmurs and so forth. My recommendation is, if you're hearing a murmur at the 6 weeks check, organize an echocardiogram. And for us at the Northern, we don't have a pediatric cardiologist, though we receive a lot of referrals for babies with murmurs. We also do exactly what we would recommend you do, is send them for an echocardiogram and an ECG that can be done at the same time at Heartwise. For those who are within the Northern catchment, those who are outside in the Eastern Health, there are other services that would offer a neonatal and pediatric echo. And if it's abnormal, then we refer on to the cardiology teams in the appropriate jurisdiction. But it will be most likely at the Royal Children's Hospital, or for those who are in the eastern suburbs at Monash. But most importantly is to identify a mama that is pathological, but also a baby at 6 weeks may not present with a mama, but might have signs of failure. And this could be cyanosis. This could be, increased respiratory rate at rest. This could be poor feeding, sweating when they are feeding, and so forth. Or when we palpate the femorals, we found that there is a lag, there is a delay, or there's a feebleness in the pulses, and that's a hallmark of significant coarctation that we don't want to miss. So we worry about the baby, organize an echocardiogram and an ECG, and made appropriate referrals to the pediatric cardiology service. The other condition we screen for and we don't want to miss is DDH, developmental dysplasia of the hips. Now, we would have picked up some of these babies and made referrals, especially for those that are dislocated. They will be picked up quite early before they leave the hospital during the newborn examination. And then there are those that have got just clicky hips, or those that have got a family history would have also been picked up in the newborn examination, and they would have been referred for a 6-week post expected date of delivery ultrasonography of the hips. But then you've got those babies who may not have risk factors, and their examination appeared normal on the newborn examination. We should not forget to still examine their hips at this point. The incidence of developmental dysplasia of the hips is around 1 to 3% of newborns, so it's not uncommon. And up to about a quarter of adult hip replacements in people aged under 60 are associated with DDH. Okay, so it's an important pathology to pick up because of long-term consequences on those hips. And so the examination will follow a particular routine in terms of looking at leg length discrepancy, if there's any, and checking for asymmetry of the creases. Worth mentioning that most of the times the symmetrical creases are actually a normal occurrence, but they need to be taken seriously, and ultrasound of the hips be organized. Otolani and Barlow's must be performed. The image you're looking at there has got both procedures being undertaken. The way I remember these things is Otolani has got an R right at the beginning. Barlow has got an R in the third position of the word, but Otolani is right at the beginning there after the O, and R is for reduction. So Otolani attempts to reduce a hip that is already dislocated back into position. And so I'll show you a picture on how you hold. We don't have time to look into all the details of this. Whilst Barlow's, which is the one on the left hand on the left foot of the left leg of the baby. I'm wavering the case. I'm not sure whether you can see it. So Otolani is a reduction test. So the hip is located, you're trying to put it into position, which is the one on the left. The right one is the Barlow's. Okay, so you're trying to see whether this hip is unstable and that they can be pushed out of the acetabulum. And if it does, in both situations, there will be a crank that will be felt on the finger that is on the greater trochanter. And if that's the case, the hips are unstable, they will need to be treated properly and investigated properly. The investigation is obviously you follow up with a hip ultrasound at that point, and you refer to the hip clinic. Again, depending on where you are, the hip clinic, we use the Royal Children's Hospital for us in the northern. Other jurisdictions have got other places where they refer these kids to. And that's the baby having the hip assessment being done. And asymmetrical thigh creases are important to look at. On the top bit there, that's the normal creases that you see, right, in the pubic areas. The middle one has got an extended crease, which is abnormal. The bottom one has got extended creases right to the bottom, which are also abnormal. And you can look at the leg creases. They must be symmetrical on both sides. Asymmetry suggests pathology on the side of asymmetry, and a hip ultrasound is the starting point. Physical examination, such as abduction, restriction in abduction, are important, and also the limb length, or the Gilliard's sign, which is the height of the hips when you put the baby lying supine and see which hip is higher than the other one. But sometimes you may not pick up those subtle signs. Undescended testes are an important part of this assessment. We don't want to miss them, especially when the testis is undescended at 6 weeks, should be referred on. We know that testis can stay undescended for up to 6 months, but 6 weeks is an opportunity to make that referral because of how long it takes for these babies to be assessed. And so when you feel a testis undescended at this age, should be referred on. Between 2 to 5% of full-term babies and up to 30% of preterm male infants are born with an undescended testicle. But most of these would have gone back into the sac by 6 months. You still have about 1% that will remain undescended at a year. So we always want the right people to be monitoring and following up these babies rather than keeping them in the community. I thought I would mention a word on anterior fontanelle, but quickly, part of the 6-week check is looking at growth and development. And so making sure that the baby is feeding very well, they're putting on the right amount of weight, their growth percentiles are tracking along. Overall, they still have all their primitive reflexes at this age. And it's important to establish that those reflexes are present because they are a significant neurological maturation, and make sure that there is a bonding and social development is happening. A quick word, because on the anterior fontanelle, because we do get a lot of babies referred to us because they've got a small anterior fontanelle. And what do we do with the baby as got the small anterior fontanelle, or we cannot feel the anterior fontanelle? That's the key feature of a normal anterior fontanelle, is variation in size and also variation at the age of closure. A normal anterior fontanelle will range from 0.6 centimeters to 3.6 centimeters in their longest diameter. This is at birth, and mean of 2.1. The closure is, median closure is about 13.8 months, but 1% of anterior fontanelles have closed at 3 months. Okay, so it's not uncommon. And around 38% would have closed by 12 months, and majority, 96%, close at 24 months, so which is even beyond the mean average age of closure. This is a healthy, thriving baby with head circumference that is growing accordingly. And it's important to remember as well that anterior fontanelle can not be detected physically, but doesn't necessarily mean that it is closed. And as long as there's serial growth of that head is growing and there is no distortion of the cranium or suspicion of closure of a suture, then these babies can be monitored as long as the head is growing properly. Whenever there's suspicion of premature closure of a suture, they should be referred to a craniofacial center. Again, we are going to refer them on because we don't manage these babies. We can investigate, which includes doing a plain scar X-ray just to see that the sutures are patent or if the sutures are closed. Otherwise, they might need further investigations and intervention. That brings us to the end.
Thank you very much, Kelvin. If there's any questions, please put them in the Q&A button. Okay, we've got no questions apart from a thank you, which means You've all been very thorough with your presentations. Now, before I finish up, I'd just like to do a presentation on health pathways. So I'm going to share my screen again. Now, this will be a recording, so you'll hear another voice.
Welcome to Health Pathways. Health Pathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne Family Healthcare Network in partnership with healthcare professionals and organisations in the Melbourne region. Health Pathways Melbourne provides clinicians with a single website access, comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care for their patients. This presentation will demonstrate how to access and navigate Health Pathways Melbourne, find relevant pathways and referral options for this topic. Navigating Health Pathways. Click the Health Pathways Melbourne website and log on. As you can see the homepage, latest updates, and recent pathway updates. To search for the relevant pathways, you can use the search bar located at the top and type in relevant websites instead. Or alternatively, you can use the table of contents on the left-hand side. There are over 40 palliative care pages available on the Health Pathways Melbourne site, which includes clinical referrals and resource pages. Following two slides provide a list of relevant and related pathways for prescribing opioids for palliative care patients. To access Health Pathways Melbourne, go to the website address at melbourne.healthpathways.org.au. Available to general practitioners and other clinicians in Melbourne and Northwestern Melbourne PSN practice. If you don't have access to that, the QR code there, or send us an email through to info@healthpathways.org.au.
Thank you to everyone for listening tonight and for joining us for this webinar. We'd like to thank our three speakers for their very informative presentations. Apologies about the health pathways. They were paediatric websites, not palliative care sites. I look forward to seeing you at our future webinars. Now, we've just had, yes, the only two comments we've had in there are both thank you. So thank you to everyone for joining us and thank you to our guest speakers. We hope you have
there's a question in there. There are two questions actually.
In the chat?
At the last minute, in the chat.
Yes, thank you.
First one says, not all parents book in for a 6 weeks check. Are there any suggestion to encourage the parents to come in? And the second question is regarding cow's milk protein allergy. How long do we wait before we attempt a rechallenging? Which you might answer the second. I might just chip in with the first one there. The 6 weeks are routine, and therefore they are encouraged by all health practitioners, including the maternal child health nurses who are visiting and the domiciliary nurses who visit in the first 1 week of life. So if it has been missed, it will be picked up somehow because this child will not have an immunization record at 6 weeks. So the government will be following up and say, what's going on? You haven't had your 6 weeks immunization. It means that they haven't had their 6 weeks check as well. So it is something that we assume from the hospital side of things that it will happen routinely because of how routine it is and the checks and balances that have been put in place. So obviously, yes, GPs, if they notice that they've received a discharge summary or a discharge note to say this, your child has been discharged, they'll book in a 6 weeks check. Otherwise, the council will follow up on the families.
Yeah, I agree with Kelvin. So we all, when we discharge babies home, we all tell parents that please make a 6 weeks check with their GPs. So we will emphasize more. Yeah. Okay, so the question, this is a very good question. Yeah. So what I'm going to do is just 1 minute. So I'm going to talk about cow's milk protein allergy algorithm. So also I will answer the question as well. So I'll just share.
Well, whilst Wech is sharing that, no, maternal child health nurses are not trained to perform 6 weeks check. That's the answer to the other question.
Can you see it? I just shared. Can you see it?
Yeah, we can see the slides, Wech.
Yeah. So I think this is very important. I'll just I deleted some slides because I worry I'm over time, but actually my time was really actually not over time. So I'll just go through these 3 algorithms. So, and if there are signs of anaphylaxis or immediate reaction, then the diet elimination is recommended. And then you just do a RAS test because it's quite easy to do. Because a lot of GP practice, you don't have a skin prick test. And also if a baby just has reaction, recently you can't really do skin prick test. They have to wait for 4 to 5 weeks at least. But you immediately can do serum, IgE, RAS test. So if the serum specific IgE test is positive, then child, you can make a diagnosis. So child is diagnosed with cow's milk allergy. So if IgE test is negative and the symptoms improve after diet elimination. So how long that elimination? I would at least 4 weeks. Yeah, so mom has to be on dairy, and you have to tell parents have to have mother has to have a strict dairy-free diet. Yeah, so no chocolate and no yogurt, no cheese. Yeah, and try for 4 weeks, and then you can do an oral challenge. So I normally ask a mom to do. So can start to introduce dairy and see what the symptoms reoccur. So if symptoms reoccur, even the RAS test is negative, the diagnosis is confirmed. So this is what I mean about clinical diagnosis. Yeah, that's elimination and re-challenge. That's the diagnostic. So it's not a really RAS test or skin prick test. So if symptoms don't reoccur, then diagnosis of cow's milk allergy is excluded. Yeah, so this is number 1. And the second, if symptoms are not consistent with the anaphylaxis or immediate reaction, then elimination diet is recommended. So if symptoms improve, then oral challenges should be done. So, if on diet and dairy-free diet, if a symptom improve, didn't have a reaction, and then you can do challenge. So I would at least 4 weeks. Then the symptoms reoccur. If symptoms reoccur, and then diagnosis confirmed. See, this scenario even doesn't involve any the skin prick test or RAS test, because a lot of them can be mediated by non-IgE antibody. So if symptoms don't reoccur, then you can exclude diagnosis of cow's milk allergy. So it could be something else. So number 3, if symptoms don't improve after elimination diet, this eliminates the diagnosis of cow's milk allergy. Because you're on strict dairy-free diet and the symptoms didn't improve, so this baby, you can refer to specialist, yeah? So hope this help or hope I answer the question. So because milk protein allergy, how long do we wait before? Yeah, so at least 4 weeks. So
Lovely.
could be longer, yeah? Can maternal child nurse perform 6 weeks check? I prefer GP to check 6 weeks. Yeah. So I think Kelvin stated so clearly how many aspects we need to cover in the 6 weeks check. Because like congenital heart disease, for example, you know, even at the birth, like ASD, VSD can be missed because at that time, pulmonary artery pressure could be quite high. So the left to right shunt could be quite minimal. And then you couldn't hear the murmur. But 6 weeks, so pulmonary artery pressure dropped to the minimal. So, and the left to right shunt would be quite obvious. So at that time you can hear the murmur. So I prefer GP do a proper 6 weeks check.
Thank you. Now, I don't think we've got any further questions now. So thank you again to our presenters and for everybody who's joined us online this evening. We hope you have a good evening.
Yeah, thank you very much, Cassie and Richard, for your invitation. And,
You're welcome.
And thank you for everyone attending. Yeah, have a good evening.
Thank
Bye-bye.
you. Bye.